Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by BWIL Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please do introduce yourself in the chat by entering your full name, affiliation, and email. Please do remember to stay muted unless you are speaking. We do encourage using the chat and or the raise your hand feature to pose questions, share perspectives and resources throughout today's session. We would love to have everyone with their cameras on as this does increase connection and engagement. However, we do understand that some situations don't allow for that, but if you are able to, we'd love to see everyone's lovely faces. And if you're having connection issues, please privately chat Karen, our wonderful Echo IT, for assistance. And as a note, these sessions are being recorded and they will be shared on our website. Therefore, we kindly ask that no personal health information be shared at any point throughout the session. This includes in conversation or in the chat. And any personal health information is things like names, addresses, any appointment dates, that kind of information. And additionally, so you all know, these slides, the slides that we'll see from our didactic presenter from today's session, they will be uploaded and shared on iEcho for your future reference, and they will also be shared in a post-session communication email. So everyone will have those after the session. At the end of the session, the ECHO team will be sending out a post-session survey link. We kindly ask you all to complete it as it does provide us really insightful feedback on how to refine these sessions, topics you'd like to hear about, and how to better address your priorities. And finally, ECHO is an all teach, all learn environment. We encourage everyone to participate in the conversation and raise questions. And let's continue making every effort to have this space that is respectful and safe for all of us to learn together. We'll move on to introductions of our team and our presenters. I'll begin with Dr. Shorter, who is also our didactic presenter and lead specialist for today.
Hey everybody, Daryl Shorter. I'm down here in Houston, Texas at Baylor College of Medicine. I'm an addiction psychiatrist and the director of our addiction psychiatry fellowship, and I'm in clinical practice at the Menninger Clinic. Thanks.
Thank you, Dr. Walker.
Hello, everybody. Crystal Walker, physician assistant with a doctorate of medical sciences, and I am currently the director of substance use disorders, medical and clinical services for MHMR of Tarrant County in Fort Worth.
Thanks, Dr. Walker. Dr. Kowalczyk.
Alicia, Dr. Kowalczyk here at Baylor College of Medicine, Department of Family and Community Medicine, and I'm an addiction medicine specialist working with Santa Maria Hospital.
Thanks, Dr. Kowalczyk. Dr. Waklu.
Good afternoon, Siddharth Waklu. I'm an addiction psychiatrist at UT Southwestern. I'm the chief of the addiction division and the director of the addiction psychiatry fellowship. Thank you and welcome, everyone.
Thanks, Dr. Waklu. And our case presenter for today, Dr. Keo.
Hi, everyone. My name is Colleen Q. I'm an internal medicine and pediatric hospitalist at Baylor College of Medicine. Thank you for having me.
Thanks for being here, Dr. Keo. With that, we'll get started with our didactic presentation. Dr. Shorter, you may take it away.
Thank you much. And go ahead and share my slides. And today we'll be talking about, this will be a little bit of a primer on substance use disorders and in older adults. There are no disclosures. Of course, the views here do not reflect on UT Health San Antonio or the government. So when I started thinking about what to discuss today related to substance use disorders in older adults, there's a lot of different ways to kind of think about this and angles from which to approach. And where I ultimately sort of landed as the seed, as the core, was in this place of thinking about the brain and the aging brain in particular. And then how our brains and our bodies then begin to interact with social systems and the sort of manifestation and treatment of all kinds of psychiatric and substance use disorders. So I want to start by talking about the aging brain. As we get older, which is something that is a blessing. I want to say that. Because sometimes when I get up in the morning and my back is hurting, it doesn't always feel like that. It is important to think about how our brains also age and how they change over time. And we can think about the structural changes that take place in the brain where there are decreases in the overall volume of the brain, and we can see atrophy and particularly the frontal and the temporal cortical areas. And this really is from a shrinkage of neurons and the loss of synapses rather than an actual loss of neurons and neuronal death. In addition to these structural changes that are taking place at the neuronal level, there are microvascular changes that result in changes that can be seen on neuroimaging, like CT scans, where you'll see white matter hyperintensities, and that's just a part of the aging process. At the cellular level, we know that there's increased oxidative stress, and that those can result in cellular dysfunction. You can have the buildup and the accumulation of age-related pigments like lipofuscin, which is a sort of a fatty yellowish brown marker of aging that can be seen on microscopic evaluation of brain tissue. And then there are also regional deposits of amyloid and tau protein. You may have heard about amyloid and tau protein, particularly if you're familiar with neurocognitive disorders and particularly neurocognitive related to Alzheimer's. And these are proteins that can again form deposits and clumps both in organs as well as in neuronal cells. Then finally, we can observe quite naturally the decline in neuronal markers as well as changes in energy metabolism in the aging brain. Then we cross the aging brain with substances. And so as the brain ages, so changes the response to substances. And ultimately, what we begin to see is that there can be an impairment in reward processing and in the experience of reward and reinforcement as a result of these changes in the brain. So like I mentioned, because of brain atrophy, you actually will see an increase in ventricular volume, and that can be associated with a reduction in euphoria and elevated mood. And that's in folks even that are just normal controls who do not have a history of substance use or substance use disorder. We also can experience or see among people who have cocaine use disorder reductions in prefrontal cortical volume, as well as hypofrontality, which is really a sort of a fancy way of saying that the frontal lobe of the brain is not working as effectively or efficiently. Where you see reductions in blood flow, reductions in metabolism within the prefrontal cortex. And then finally, there are a number of markers of reductions in dopamine signaling. And we know that dopamine, of course, is a part of the reward and reinforcement process. In addition to these brain changes, we also know that as people get older, that they use healthcare services more frequently because of the development of illnesses later in life. Of course, lifestyle choices can lead to medical and or psychiatric illness. In particular, today we'll be talking about drinking as well as non-medical use of prescription medications. As we get older, our brains and our bodies have a heightened vulnerability to the effects of alcohol and substances, and that can also be impacted by medications that people are taking as a result of chronic medical illness. And then, of course, medical comorbidities can also result in greater interaction with healthcare system, and that can be even outside of one's relationship to alcohol and substances. So taking all of that together is sort of our core understanding of what it means to be a person who is aging and has an aging brain and body. Today, we'll spend some time talking about the prevalence and risk factors as well as clinical manifestations of SUDS in older adults. We'll talk a little bit about a treatment approach for management of AUD in older adults, and then we'll also talk about some provider and patient factors that are related to non-medical use of prescription medications in older folks. So in SAMHSA's National Survey on Drug Use and Health, which comes out annually, they do break down some of that data by age, but in the SAMHSA this national survey, rather than looking at it at the age of 65 and older, they actually say that the older folks are 50 and up, which I take great offense at, frankly. But what you can see from this slide is that the percentage of folks that are experiencing either any mental illness or a substance use disorder goes down as people age. So you've got almost 50% of folks 18 to 25 reporting that they have had either any mental illness or a substance use disorder in the past year. And by the time we get up to the age of 50 or higher, we're looking at about a little over 1 in 5 people that might be reporting that they experience either any mental illness or substance use disorder in the past year. Interestingly enough, the prevalence of alcohol use disorders in older adults these studies, which is defined as greater than 65 years old, that has been going up. So back in 2013, and this is data taken from the NESARC study, the National Epidemiologic Survey for Alcohol and Related Conditions. Back in 2013, the prevalence of alcohol use disorder was about 1.5%. But what has been observed since that time is that AUD and misuse prevalence has actually continued to rise and is increasing by about 0.5%. We're seeing increases in rates of alcohol use, binge drinking in particular, as well as alcohol use disorder, with sharper increases among women and persons with multiple medical comorbidities. Recently in 2023, NIAAA estimated that about 1 in 22 adults had AUD in the past year, and about 1 in 8 older adults engaged in binge drinking at least once in the past month. So already we should begin thinking about how we might approach our diagnostic assessment of patients that are 65 years and older, and really talking to them not just about sort of the presence of alcohol use disorder, but also their relationship to drinking and drinking patterns. When it comes to substance use disorder prevalence, kind of outside of alcohol, it is important to note that alcohol accounts for about 77% of substance use disorders, and that drug use disorder prevalence is actually substantially lower at about 0.2% of older folks. Now, although alcohol is certainly the most common, second most common is defined as prescription medication use, and that includes both benzodiazepines and opioids. With about 16% of substance use disorders in Medicare beneficiaries stemming from benzos and opioids. And opioids by far are associated with the highest disease burden. Cannabis use disorder can be seen in about 10% of adults with another substance use disorder, and past year prevalence is about 1.3%. And tobacco use disorder affects about 4% of older adults. Now, you'll probably be thinking to yourself, well, I'm not seeing methamphetamine or cocaine or heroin on this list? And that's quite true. Although those substance use disorders certainly are present among older adults, they are at substantially lower prevalence than alcohol and prescription medications. I also think it's kind of interesting and to think about generational differences and why it is that there may be certain patterns of drinking among certain generation. It turns out that baby boomers and Gen Xers have higher rates of drinking and heavier drinking patterns. They are also less likely to abstain. And I think that it's because of this in particular that we're beginning to see that the reduction in abstinence as people are getting older, because baby boomers are now representing and Gen Xers are getting ready to represent those folks that are 50 and up and 65 and up. Also turns out that folks that are late Gen X or early millennial US males have higher alcohol consumption than either earlier or later cohorts. Now, this is really in counter-distinction to millennials and Gen Zers, who are much more likely to abstain from alcohol entirely. They're also reporting lower weekly alcohol consumption and more likely to disapprove of regular alcohol use and to perceive lower safe drinking levels. So when it comes to boomers and Gen Xers, they also have, in addition to higher rates of drinking, higher rates of alcohol-related morbidity. So that persistent heavy drinking and increased binge drinking can take place particularly in midlife and older age. It's also thought that because of socioeconomic vulnerability related to job and wage stagnation, that might actually be a contributing factor for why it is that they have been experiencing sort of these higher rates of alcohol consumption. They also may be experiencing worsening physiological and mental health profiles outside of their substance use that might be contributing to why it is that they are engaging in alcohol use in this way. And among boomers and Gen Xers, there seems to be less disapproval of alcohol consumption. Now, this again is very different from our millennials and Gen Zers, who show more protective trends. So where there's increases in abstention and more moderation, they also report less peer pressure and feeling more health conscious. And it's interesting because millennials and Gen Zers will also talk less about the use of alcohol as a rite of passage, particularly during adolescence and young adulthood. They're also more likely to disapprove of regular alcohol use. And because we have been observing delays in role transitions, getting married, having children, as well as hustle culture among millennials and Gen Zers, that might also promote moderation. At the same time, abstinence rates do go up as people get older, and this is probably because of the health concerns that people experience, and how abstinence is ultimately just a safer bet when you consider the medical illnesses that someone might be experiencing, or if people are taking other types of medications and they are concerned about having an adverse medication reaction or interaction with substances. The physiology also changes, and in particular, lower total body water and altered metabolism can result in people having more intoxicating effects and health risks as a result of taking in the same amount of alcohol or other substances that they might have used when they were younger. People can also experience more confusion, cognitive impairment, and falls, which makes substance use less attractive. And then from a social standpoint, there may be just fewer opportunities to drink because people they're not working anymore because they're retired. They're less likely to go to happy hour after work, or maybe they're experiencing grief or bereavement from losses. And so the people that they might have engaged in alcohol consumption with are no longer present. And then because people may move to be closer to family, or they may move into certain types of living environments or assisted living, their social networks might change and alter as a result, and may also reduce access to alcohol and use of alcohol. And so, because of these major life transitions that people can experience, really thinking about their relationship to alcohol and substances can be a part of the experience of being an older adult. It's also important to note that the reasons that people use substances change with age, and that among older adults, they are more likely to use substances for medical reasons, for help with sleep or insomnia, for anxiety, for pain management, and perhaps less likely to engage in recreational or risky patterns of use. Depression and social isolation actually can serve as a risk factor or a protective factor. So if someone is experiencing depression and they recognize that their depression gets worse with the use of alcohol or these medications, or non-medical use of prescription medications, they may be less likely to drink, or that depression or social isolation can actually drive people to engage in that substance use. Other barriers include limited opportunities and motivation, sort of globally across the board, having less access to substances, not really experiencing peer pressure to engage in drinking or other types of substance use, and then over time developing more negative attitudes toward illicit substance use. So, with all of that in mind, it is important for us to kind of think about and reconsider how DSM-5 manifests in older adults. And so, rather than kind of thinking about someone maybe taking substance in a greater amount than intended, it's important to note that older adults may become impaired even when they're taking the same amount that they took when they were younger because of those physiological and brain changes that I mentioned. They may also not realize that their use is a problem. And so asking about efforts to cut down or control use may not necessarily be present. And so it does become important in those moments for us to have an understanding of whether or not the older adult actually thinks that their relationship to alcohol or substances and behaviors around them is problematic. It turns out that, that because they have experienced changes in their roles in terms of maybe they're not working, maybe they're living alone. That role impairment is not necessarily something that that are older adults will see as it relates to their relationship to substances. The same thing may be true in terms of social social roles or working roles because they're not engaging in social networks in the same way that they once were. Um, Impairments in driving among older adults can occur for lots of different reasons that are not solely linked to a relationship to alcohol or other drugs. I mean, you might have cognitive problems and other types of memory issues, medical illness, visual problems, hearing problems, perceptual problems that can also contribute to impairments in driving. And um, thinking about like just the relationship of dangerous situations to use, maybe have to sort of zoom out and begin to think about that from a much broader perspective. Medical consequences can occur in the context of substance use and can be quite serious. And oftentimes, this is how people might present to us in our clinics and in our hospital settings because they've experienced confusion or had a fall or some sort of injury. And so maybe that's one way of beginning to have that conversation with folks. It's important to also note that tolerance can become quite fluctuant and can change for people over time, and that they may experience a symptomatic impairment without even a need to go up on the amount or go up on the dose of a particular medication. And of course, withdrawal can present in a lot of different ways, including more subtle symptoms like confusion. So, although the vast majority of older adults are going to either be abstinent or have very, very low risk, it is important to note that there is a category of folks who are drinking or have at-risk use of alcohol. And those are going to be your folks who are over the age of 65 who are drinking more than 7 drinks per week. We've also got folks that have harmful use where they may be experiencing adverse medical, psychological, or social consequences, but not yet meeting criteria for alcohol use disorder. And these changes that they're experiencing, these consequences that they're experiencing are just related to the process of aging. And so that they're experiencing damage, despite the fact that they have maybe not experienced damage or problems before. And then, of course, those meeting criteria for AUD. So when we think about some of the medical complications associated with alcohol use disorder in particular, I've mentioned some of these. We've got falls, confusion, and cognitive impairment. These things can occur even at lower levels of consumption because of the physiological changes that I mentioned. There are several medical illnesses that are directly related to alcohol consumption: hypertension and arrhythmia, liver disease, pancreatitis, cancer, particularly oropharyngeal cancer, breast cancer, colon cancer, liver cancer, or hepatocellular carcinoma. People can also experience a number of neurological and psychiatric complications, particularly neurocognitive disorder. And of course, we've mentioned things like sleep, systemic inflammation, impaired reflexes, and coordination. So in our approach to taking care of the older adult, it does become important to really think about how we might utilize a validated tool in an effort to do appropriate screening for alcohol use disorder. So I've listed several here that have been validated in older adults. We've got the Audit C and the Audit, as well as the Geriatric Short Michigan Alcoholism Screening Test. And I've included a link to that test here. Again, in addition to just asking questions about the amount that someone is drinking, because the consumption is important and the frequency of consumption as well as the amount of consumption is an important thing for us to ask people about. It does become important for us to also ask questions about the psychosocial stressors that people might be experiencing. For example, are you experiencing grief or bereavement? How is that perhaps interacting with your relationship to alcohol or substances? How are you adjusting to retirement? One way to get at that might be to ask people, what's a typical day like for you? Do people have a schedule or a routine? Do they have a time that they get up in the morning? Are they eating and ingesting enough calories? What's their diet like? Where are they going during the day? Are they interacting with other people? And if they are interacting with other people, in what capacity? Are they primarily on the phone or texting with other folks? Mobility becomes a major issue for folks as they get older, and being able to actually be out in the world can sometimes be a challenge as well. And of course, there's the shift in one's identity as a result of retiring. Like, who am I now that I'm no longer working a particular job? And sometimes in cases where retirement is a result of it's a forced retirement as a result of either aging out of a particular occupation, or because of medical reasons, retirement can be very, very sort of psychologically complicated for people. Folks that are living on a fixed income might experience a significant amount of financial stress, which could, of course, further complicate their relationship to alcohol and substances. As I've already mentioned, pain and chronic pain, I think we all know, is a major risk factor for opioid use disorder, but also for alcohol use disorder. And certainly medical comorbidity can be a factor in why it is that people might develop problematic relationship to alcohol or other substances. So a lot of questions that we can ask on the psychosocial side of things with our older adults can help us to better understand why it is that they may be at particular risk for going on to develop an alcohol or substance use disorder. So when it comes to our management recommendations, these things are really quite standard. The first thing, of course, is that we would want to evaluate for the presence of alcohol withdrawal syndrome and treat that. Benzodiazepines, although I have mentioned them several times in the context of being a concern, benzodiazepines really do remain the mainstay of treatment. And among older adults, using something like lorazepam or oxazepam become preferred due to their method of metabolism. It is important to really try to combine pharmacotherapy with behavioral interventions. CBT and motivational enhancement therapy become very critical components of our overall treatment strategy. 12 steps facilitation can also be a really critical, important part of this, especially if we're thinking about folks who don't necessarily have a lot of structure, who have lost their schedule, and who are really struggling to have connection with other people, and they've seen the loss of others in their social network. Going to 12-step or other types of meetings can be really, really helpful, and creating a sense of community, a newfound community, especially if someone is also trying to make changes to their relationship to alcohol and substances. It is important for us to also make sure that we're getting releases of information to talk to medical providers and other providers on the team. One, it's important for us to know what, from an accurate standpoint, sometimes our patients aren't always the best at giving us the history. So we want to make sure that we're having conversations with them, particularly around relationship to substances, because we want to ensure that there are no other medical complications or medication complications as a result of people making changes to their relationship to alcohol or drugs. And whenever possible, engaging family and social supports becomes another really critical part of this work, so that we can enhance the overall quality of the social network for the individuals that we're working with. I'll just say a quick word about pharmacotherapy. As you all know, there are three FDA-approved medications, but gabapentin and topiramate have certainly risen to the level of being first-line treatments for alcohol use disorder. Considerations to make when it comes to AUD pharmacotherapy in folks who are older is how frequently we're monitoring their liver and or their kidney, as well as letting people know about the potential side effects that they might experience. That's even outside of drug interactions that they might have if they're taking other medications for other medical illnesses. So wanting to let people know if they're taking naltrexone, the possibility of nausea, headache, or dizziness. If they get the Vivitrol injection, there's also the possibility of the injection site reaction. These medications do become contraindicated in persons with liver disease like cirrhosis, acute hepatitis, or if they have a substantial elevation in their LFTs or liver enzymes, because that risk of hepatotoxicity is certainly present. Of course, in older adults, you are more likely to see an improvement in adherence if you use Vivitrol, but of course, there can sometimes be some challenges related to access. When it comes to acamprosate, this is a medication that is processed by the kidneys rather than the liver. So you're going to want to monitor creatinine levels, warning patients about the possibility of GI symptoms like diarrhea and nausea, as well as anxiety and depression. And then adjusting the dose of this medication may be required in cases where people have moderate kidney disease or kidney impairment. So that's why that creatinine level is going to be really important. It can be very difficult for people to remember to take 3 doses of a medication because acamprosate is a 3 times a day medication. And so particularly in cases where you might be concerned about cognitive impairment, I think it becomes important to do your mini mental status exam or perform a MOCA to make sure that people can retain that information and that cognitively that they feel capable and able to remember to take a medication 3 times a day. It's difficult, however, even in folks that are not older and who presumably do not have cognitive impairment. Of course, there's also gabapentin. Again, this is one of our first off-label medications. We're going to want to monitor creatinine levels here. But the nice thing about gabapentin is that it can also provide some benefit for other indications from that medication. So if people are experiencing things like chronic pain or neuropathic pain, if they're having problems with insomnia or anxiety, gabapentin in this context might be a really great medication for them. Again, you'll have to adjust for kidney impairment or kidney disease, and of course, monitor very, very closely for the potential for abuse. And then topiramate or Topamax, again, people can experience numbness and tingling. Again, that baseline mini mental or MoCA exam is really important with Topamax or topiramate because people can sometimes experience some cognitive challenge or cognitive dulling as a result of being on that medication. One of the nice things that people like about topiramate, however, is that it can sometimes contribute to weight loss. Just keeping in mind that if you have somebody on that medication, that you'll move to taper the dose of that medication rather than abruptly stopping. And of course, there's also a risk of encephalopathy in folks that have advanced liver disease. So again, monitoring very closely. Finally, we've got disulfiram or antabuse. Again, people would have, this is aversion therapy, so people really need to be abstinent in order to start this medication because of the vomiting that it induces. There can be a risk of hepatotoxicity, and you may have to adjust the dose of this medication and reduce it in cases where there is the presence of either kidney disease or liver disease. And disulfiram, sort of in comparison to the other medications that I mentioned, has a particular polypharmacy risk when combined with other meds. Okay, so now we'll talk a little bit about non-medical use of prescription medications. Again, opioids and benzos have been identified as the class of medications that are at greatest risk for older adults. And there is both prescriber contribution to this as well as some patient-related factors. On the prescriber side of things, making sure that we are adequately screening people for a history of a substance use disorder or alcohol use disorder. Performing a complete and thorough assessment of patients becomes really, really important so that we can ensure that we don't inappropriately start or inappropriately prescribe medications to people for folks that are at a higher risk. And also, it's important to provide clear instructions on drug use and the potential interactions with other prescribed medications that people might experience. So making sure that we are very clear in helping patients to understand their risk. On the patient side of things, people might omit or double doses, and that can make it very difficult for them to kind of like remember what they're doing or to take medications in a consistent fashion. People might consume expired medications. They may share medications with other people, especially around in relation to finances and living on a fixed budget. Other risk factors include chronic pain, where you have a substantially higher risk of going on to develop non-medication use of a prescription medication in that context. Cognitive impairment can, of course, lead people to have unintentional misuse because they may not remember that they are taking medications or unintentionally double doses, as I mentioned. And folks that are at a lower socioeconomic status and gender, and in particular, women at a lower SES are at a higher risk of developing non-medical use of prescription medications. When it comes to medical complications of this, among benzodiazepines, things to be aware of and to warn folks about include delirium or an altered sensorium as a result of taking benzodiazepine medications. People can also experience acute respiratory failure. They might have falls or car accidents. Withdrawal and dependence can be a major, major factor with benzodiazepines in particular. And of course, we should be warning folks about the increased risk of dementia or neurocognitive disorder as a result of chronic benzodiazepine ingestion. Opioids, of course, we have the increased risk of overdose, confusion, falls, and deaths. But it's important to recognize that as the body ages, that there are reductions in opioid clearance, which can further heighten these risks because people aren't metabolizing and eliminating the medications as efficiently as they were and effectively as they were when they were younger. All of this together can lead to higher rates of hospitalization, as well as a sense of loss of independence and increased mortality. So these things do become really important things for us to talk about with patients. When it comes to treatment, we ultimately want to reduce the patient's reliance upon opioid medications. To the extent that we can marshal some of the old school approaches like heat and cold therapy, making sure that we've got referrals to physical medicine and rehab and physical therapy, as well as other associated modalities. So perhaps people need to be referred to our chronic pain management services, referrals for hydrotherapy or chiropractic, or getting psychotherapy, CBT specifically for chronic pain. Those types of treatment modalities can be very, very helpful with reducing reliance upon opioid medications. Of course, we're going to want to prescribe analgesic medications like NSAIDs, acetaminophen, topical medications to help with pain relief. Benzodiazepine tapering can be a really important part of the work that we do. And depending on which source you look at, the speed with which you can reduce the dose of benzodiazepine is really, in some ways, kind of a matter of the art. Rather than the science of medicine. A lot of this might have to do with whether or not the person has an underlying psychiatric condition like a depression or in particular an anxiety disorder. In cases where people do have a primary psychiatric condition or a primary anxiety disorder, dose reduction might need to go a bit slower, and so that you might have time to start other psychiatric medications or get people actively engaged in psychotherapy so that they are supported while you're tapering benzodiazepines. Uh, there is some evidence to suggest that it is better to use short-acting formulations of benzodiazepines in older adults in order to minimize some of the cognitive side effects that one might experience. And of course, last but certainly not least, the use of medications for opioid use disorder, naltrexone, buprenorphine, Suboxone, and or methadone to manage opioid use disorder among older adults. So some final thoughts. The use of alcohol and prescription meds really represent a particular risk for older adults for many of the reasons that I just discussed from a brain standpoint, from a body standpoint, from a social standpoint. And the potential impact of other substances, including tobacco, should really be considered. One thing that we really want to make sure that we do is screen folks carefully, and that we account for the particularities of the aging process and where people are in that developmental stage of life, so that we are better able to identify harmful substance use. And of course, as always, pharmacotherapy in combination with psychotherapy and enhanced social support can really greatly reduce the harms that older patients might experience and promote abstinence. And here are my references. Thank you.
Excellent. Thanks so much, Dr. Shorter, for this great presentation. Are there any questions from anyone in our learning network for Dr. Shorter on the slides he just presented? Go ahead, Dr. Waklu.
Dr. Shard, that was an excellent presentation and excellent overview of SUDS in the geriatric population. I do just a few comments. There's a comment in the chat box about uh, uh, that geriatric patients struggling with SUDS, the cost of naltrexone, and a lot of providers not being open to clearly are relevant points. And I have at times advise patients to use GoodRx, which tends to be a cheaper option than going through insurance, because at times cost, even though naltrexone is generic, the cost can be some coverage is not really not adequate. A thing to remember is in the geriatric population, in a 75-year-old with an alcohol use disorder, what are your goals? Are your goals complete and total absence, or is your goal harm reduction? And sometimes in that geriatric population, I have patients coming and telling me is that Dr. Baklo, my goal is not to stop. I don't know how many years of life I have left. I want to still enjoy my alcohol. My goal is not to stop. Can you do something to help me drink less or drink in a safer manner? So again, we have to realize that our goals may not be. This is not a 30-year-old with an active job and family and kids that's affecting a lot. And this someone that is has an alcohol use disorder or has unsafe alcohol use. What can we do? So that's I think that's a good kind of clinical list to remember is because the what is the patient's goal might be quite different from the family's goal, the family and again, I also want, I just don't want to give the impression that it's really important to treat substance use disorders in the elderly because you can really take care of a lot of medical complication that Dr. Shorter mentioned. So we can really decrease medical morbidity and mortality, but also at the same time remember what the patient's goal are and meeting the patient where they are. As regards alcohol pharmacotherapy, I have had some challenges in the geriatric population is in using acamprosate and topiramate and gabapentin because they're all renal excreted. And patients, by the time they're in their 70s and 80s, have developed CKD, they're up to at least CKD 2, 3, and those become challenges. Sometimes I've used fairly low dose gabapentin for patients, and even on low dose gabapentin, they develop neurological symptoms, they develop twitching and all. So I think one has to be very careful about this alcohol pharmacotherapy. Topiramate again, you have the geriatric population which is at higher risk of cognitive issues, and then topiramate itself causes cognitive issues. So again, so it's a very limited, even though we have these pharmacological agents, it's very limited. Again, honestly, outside of naltrexone, I'm not sure what we can really safely use in the geriatric population. Kind of becomes a challenge. Uh, uh, the third point, I just want to share an experience I've seen. Patients who all through their life were social drinkers and just drank modestly, when they develop a mild cognitive impairment or Alzheimer's or vascular dementia, I've probably about in the last 5, 6 years, about at least once a year, I've seen it where people were social drinkers all their life and then they develop a cognitive disorder and there is just absolute loss of control of alcohol use. That alcohol use just kind of ramps up. And the challenge is they don't remember they're drinking more. They have no recollection, and they have so that's a kind of another diagnostic challenge, or sorry, not a diagnostic, but a practical clinical challenge is that people don't recall that they're drinking, and they don't think their drinking is causing any problems because they have no recollection of the consequences of their alcohol use. So, just wanted to share some thoughts. Thank you.
No, I couldn't agree more with what you're saying, Dr. Watley. Thank you for all of your insights. Yeah, I think when we're dealing with folks that are oftentimes in our systems for either medical and or psychiatric reasons, there's kind of an urgency, or at least an urgency that we might experience around helping people to reach total abstinence because we're thinking about the medical and the psychiatric complications that they might experience as a result of ongoing drinking or substance use. But the reality is that I think it all begins with one, the patient's goals, as you said, and then two, the quality of the relationship that we establish with patients, right? Oftentimes, that first or second or third or fourth conversation or session with someone is not necessarily going to be the one where they have the miraculous light of insight descend upon them and all of a sudden they decide that they want to like just be sober from everything. Like that's just not the way that reality works for many people. And I think that there can be some differences between people in terms of like what medications that they may or may not respond to, particularly if they are psychiatric medication naive or not. So oftentimes by the time someone gets to me, they have tried multiple antipsychotic medications. They've probably been on a couple of medications for bipolar disorder. They've been on every antidepressant known to humankind. And so the idea of going on to a medication like topiramate for that particular individual may be very different than it is for someone that is psychiatric medication naive, that's never taken a medication like this before and might do better on something like naltrexone. So our really complete medication history, I think, can help give us some ideas about what it is that someone may or may not be able to respond to. And of course, checking baseline labs and making sure that from a kidney and a liver standpoint that the person is not at risk. And then also, I think just getting in the habit of checking drug-drug interactions for everything. And also asking people about any other supplements that they might be taking. Like that's just good practice now. And so we can give people kind of complete information about what it is that may be going on from a medication standpoint, as well as a substance standpoint, as well as from a psychiatric standpoint and from a medical standpoint. Like we're dealing with really quite complicated scenarios. And people are like, listen, I'm 75 years old. I'm not going to stop drinking. Like I'm just not going to stop doing that, or that I'm just not interested in that part of it. And say, okay, well then, in a situation like that, how can we help you to perhaps either reduce the harms from your drinking, especially when you introduce things like what you just said, like they may not even remember how much they're drinking, or they're just like, I'm just not interested in that. So maybe these are folks for whom naltrexone can be an option, because it might maybe help them to drink a little less, to perhaps experience a little less reward from it and reinforcement from it. So lots of creativity and opportunities to kind of talk to people about about their relationship to substances and then really tailoring it to an individualized approach. I've got a patient who's 75 years old right now who's had like a 40-year history of opioid use disorder, and he's on like 2.5 films of buprenorphine. He takes like 3 milligrams of buprenorphine of Suboxone a day. And he's pretty meticulous about the way that he does it as well. But like this is where he and I arrived after essentially trying to get him onto a higher dose. He couldn't tolerate it. And he was like, this is the dose that works for me. I'm not experiencing withdrawal and I can poop. I go to the bathroom. So I'm good to go. So no, I would not normally treat somebody with only 3 milligrams of Suboxone, but 75 years old, absolutely.
Thank you, Dr. Shorter. Thank you, Dr. Waklu, both for your insights and Dr. Shorter for your presentation. I do want to highlight Dr. Kowalczyk shared a guideline for benzodiazepine tapering, so please all take a note of that, save it, and reference it later. At this time, we will move on to announcements. Karen, whenever you're ready, por favor. Thank you so much. So to claim your CME credits for today, please ensure you have a registered account first and then text attend 101-01245 to the number on the screen no later than midnight tonight. These post-session surveys do help us shape our sessions for you all around your needs, so we kindly ask you and encourage you to complete them. Next slide, please. CSTAT offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request using the link in the chat or by scanning the QR code right there on the bottom left of the screen, and we will be happy to assist. Next slide, please. And CSAT also offers you the opportunity to present any challenge your organization is encountering and to receive live feedback from our hub of experts and broader learning community. There's no need to present a formal presentation. We provide you with the form to fill out in hopes that this assists with the presentation itself. We'll see Dr. Keogh do that here shortly. Please email us using the link in the chat if you are interested. Next slide, please. And the call for presenters for the Texas 2026 is now open. We invite professionals across substance use and behavioral health disciplines, including researchers, providers, peer specialists, and community leaders, to submit a presentation and any poster proposals. Share your innovative solutions, emerging research, and collaborative approaches that advance substance use care and recovery in our state of Texas. Submit your proposal today using the link that Karen will share in the chat, or that she has shared in the chat. Next slide, please. And the holidays are right around the corner. Therefore, please note there will be no TxRx Echo session on Thanksgiving Day. If you join, we will not be present. We will be having turkey. And on November 27th and December 25th, in observance of the Thanksgiving and Christmas holidays. We will be sending a calendar hold for the fourth Thursday of the month starting in January after that session. So we invite you to join us at our next session on December 11th. Thanks, Karen. And with that, Dr. Keogh, the floor is yours to present the case. You can take it away. Thank you.
Thank you so much. And I really appreciate that presentation. Definitely, we see a lot of older adults in the hospitalist service. So as a frontline provider and a generalist service, we definitely see a lot of patients. And so that's very helpful information for us. And they're definitely struggling with a lot of the issues you mentioned. This particular case came to me from another hospitalist in our service who they reported struggling a lot with this case, and it felt as though it was very difficult to manage. And so they wanted it to get some more attention and try to figure out maybe some better strategies how to manage complex patients like this in the future. The patient was a 28-year-old female with history of substance use disorders, including alcohol, opiates, and methamphetamines. And the patient reported a history of seizures, which she said was associated with opioid withdrawal in the past. And that was, she was pretty it seemed like she was pretty adamant about that it was associated with her opioid withdrawal, but she also had this history of alcohol use as well. She presented to the emergency room due to acute withdrawal symptoms, and she was reporting some left lower quadrant abdominal pain, nausea, and vomiting. She presented around 8 a.m., and her last alcohol, methamphetamine, and opioid use was the day before around 3 p.m. So she reported in her history about a bottle of whiskey per day for about 6 years, around 300 micrograms of fentanyl per day. So it seemed in different notes. Some were saying she was injecting, some were saying smoking. So she may have a mixed use. She reported daily use for about 7 years, and methamphetamines as well with injection. And I believe it was around the same amount of time for the methamphetamine. She did not use any tobacco products. She had reported a history of residential treatment in the past, but there was not a lot of history at all in the chart related to her prior treatments. And so it did not appear to be that she was currently in treatment at all for her substance use disorder. She did have a family history of substance use. In her interview with one of our substance use counselors, she did report her readiness to stop use for substances at around a 7 out of 10. In the emergency room, her CWA upon evaluation initially was around 15 and her COWS was 17, and she was experiencing some withdrawal symptoms. She received a 10 milligram IV dose of diazepam 3 different times over several hours, and she did have some improvement in her symptoms, but she still was reporting some more withdrawal symptoms, so she was admitted to the medicine team for additional management. The psychiatry team was consulted, and they did note that they tried to talk to the patient, but she was sleeping. She wasn't very interactive. They did not note any tremors on their evaluation. And their recommendations on the initial, this is in the emergency department, they recommended starting Depakote 250 milligrams every 8 hours, especially due to this history of seizures with withdrawal. Gabapentin 600 milligrams, tablets 3 times daily. And then they were mentioning, although the patient had this multiple substance history, to avoid giving opioids and to treat her symptomatically with loperamide, methocarbamol, ondansetron, and clonidine, typical symptomatic management for opioid withdrawal. But if she was in severe distress due to opioid withdrawal, starting the Suboxone and increasing as tolerated. So I think the concern was for oversedation and the risk of sedation issues with using both benzodiazepine for withdrawal for the alcohol use disorder as well as the buprenorphine for the opioid use disorder. That seemed to be the concern. And they were recommending lorazepam over diazepam due to the long half-life and risk for respiratory depression. So the next day, the patient overnight had received some symptomatic management with methocarbamol, hydroxyzine, and ondansetron, and she had been receiving some intermittent lorazepam. Her last dose was around 2 a.m., and then the medical team saw her in the morning. She was noted to be somnolent, but she was able to talk a little bit. She was uncomfortable. She had some tremors with the extension of her hands. She was very jittery with frequent movements, sweaty palms, moderate anxiety. And the psychiatry team recommended Suboxone or buprenorphine, 4 milligram film 1 time, and then to monitor the response. So they were saying, that she could continue to titrate this up depending on her symptoms that day. And she was continued on a CWA protocol with lorazepam 2 milligrams every 4 hours, and then the methocarbamol as needed every 3 times daily, and the gabapentin scheduled. And then the Depakote was increased that day from 250 to 500. 3 times daily. So the next day, the patient had very high COWS and CWA scores overnight. She was very tachycardic, and in the morning, she was very symptomatic and with withdrawal symptoms, multiple types, I think, with tremors and everything. So over that night, the night before, it seemed that the night team had been giving her lorazepam and the nursing staff about every 4 hours. She received about 4 doses from 10 p.m. to 9 a.m. of the lorazepam. And then around in the middle of the night, they just gave a dose of diazepam because she was so symptomatic. Buprenorphine had been given at midnight, a 4 milligram film. And then when the medical team saw her and she was so symptomatic, they decided to give more buprenorphine, 1 at 11, and for the 4 milligram film, and then another at 2 p.m. And she was started on scheduled methocarbamol it previously had been PRN. And then they checked on her later in the day, and she was still having some symptoms, but her withdrawal symptoms just seemed to improve a little bit later in the day. On day 3, they were saying she's pretty somnolent. I'm still having some nausea, headache, and dizziness. She was getting clonidine. She got two films, so 8 milligrams total of buprenorphine in the morning, and then she was continued on the other medications, Depakote, methocarbamol, and gabapentin. And psychiatry at that time had suggested a scheduled diazepam taper. I believe it was maybe 20 milligrams twice a day, but there was a discussion back and forth with the team. They were pretty concerned. The primary team was concerned about sedation, and the patient was fairly sedated, and so no benzos were given during the day, and the CWAS were noted to be less than 8 over. She was continuing like on a as needed protocol. And so the next day she was still not wanting to eat. She was overnight. She ended up getting some benzodiazepine, diazepam, and then she was started on the 5 milligrams 3 times a day for anxiety. The buprenorphine was given 6 milligrams, so she got the 2 milligram film, 3 of them, and that was at one time together. And then she started getting hydroxyzine as well as needed. And then after that, she really started to improve. So overall, she was able to take oral intake, and they continued with a buprenorphine taper. So 4 milligrams the day before discharge, and then the 2 milligrams on the day of discharge with films. And then where the patient was discharged, buprenorphine was not available, and it was not able to be given there. And so patient was that was the goal, was to taper the patient off buprenorphine, knowing that the medical team knew that from the beginning of the hospital stay. And her discharge medications were gabapentin, 600 milligrams 3 times daily. Yes, and methocarbamol, 750 milligrams, like a taper, basically, for symptomatic management, and then some vitamins. So I'm just curious from the experts in the group for this case, with patients who are presenting for withdrawal management from multiple substances, including opioid, alcohol, and also methamphetamines, what are some best approaches about how to, evaluate these patients and kind of give them the best possible treatment to prevent complications like sedation, and to prevent, a very long hospital course? And then how effective are some of the adjunctive therapies like Depakote or gabapentin when for withdrawal, especially when it's happening with multiple substances? And I think this comes up, and I've seen this in some other cases for alcohol use disorder, that, if the patient is getting sedated, but they're getting multiple, if they're getting Depakote and gabapentin as well, which can be sedating meds, so that complicates a little bit the management. And then, thinking about, of course, this patient wasn't able to get buprenorphine, but what are some key strategies for discharge planning for patients with multiple substances like this, in the case that the patient was able, perhaps to transition to outpatient treatment? But that's it. Thank you.
Excellent. Thank you, Dr. Keogh. At this time, the floor is open for questions and any comments from the audience or from our hub.
I don't have a question, but I have more of I guess, a comment. I work at a nonprofit organization providing substance use and mental health treatment to individuals who have opioid use disorders. And one of the things we notice is that when a client is seeking Suboxone treatment with us, we don't typically prescribe prescribe the medication when someone has a benzodiazepine use. We recommend them for detox services, because given Suboxone and Ativan, or given Suboxone and benzodiazepine can cause they counteract with each other. And so that's, I guess, a food for thought per se, just so I don't know if that impacts the length of stay of the client, because they were probably experiencing the symptoms or withdrawal symptoms, given that both medications were provided, at least from what I understood. So I thought I'd share that.
So if that patient unable to do detox, what do you do? If the patient on the benzodiazepine cannot be detoxed,
we recommend them to go to the nearest emergency room, and our nearest emergency room has protocols in order for them to withdraw safely, versus us that we're not highly equipped for that. Especially because we're more of an outpatient service. They render that service to them. Um, and our emergency room actually coordinates with our detox center in our community, so that way they can get admitted sooner than we would be referring to the detox center, if that makes sense.
Because it's safer for them to be on Suboxone and the benzo than for them to be out there using fentanyl and the benzo.
Yeah, we don't typically prescribe it. And the reason why is more so because it slows the heart rate down for the client, and then sometimes it counteracts with the substance that they're already using. So that's typically why we recommend them to go to detox. It just depends on the community. Also, like that, I don't know the setting of where your area is at, but I know in our area it's more like we're a small community, and so it's easier to kind of refer um, and get them service sooner than expected. I hope that answers your question.
Yeah.
Yeah, I guess I'll break in here. I think in a situation where you have someone who is coming off of opioids and alcohol at the same time, it does become critically important to stabilize both, and that using opioids and benzodiazepines together is completely appropriate in this situation where you have someone that is an elevated CWA and an elevated COWS score. Now, it may not be appropriate at certain levels of care to do that. This might not necessarily, but it might be required to do it at certain levels of care if that person's refusing to go to the ER, or you're trying to talk them into going into a higher level of care like a detox program and they're just flat out refusing. In a situation like that, one might have to really self-reflect and say like, okay, well, what do I feel comfortable with? What do I not feel comfortable with? Having said that, it is appropriate to stabilize both at the same time. It is actually recommended. And so I think with one of the challenges that we're having with fentanyl is that we're always chasing how much Suboxone to give in a situation like this, because it can feel, we're pushing the dose with fentanyl, basically. At least that's what I'm finding I'm doing clinically. And so what used to work for people, the 4 mg on day one, the 8 mg on day one, is no longer holding people. And so it is not uncommon to push to 12, to push to 16. You've got people that are just slamming folks with 24 and 32 mg of Suboxone on day one. And so I think that perhaps some of this case could have gone a little differently if there had been more aggressive management of the fentanyl use disorder alongside using the appropriate Ativan for managing the CWA. And I mean, I'd be really interested in digging in to see what CWA scores were looking like, and how soon after an elevated CWA someone was getting the lorazepam 2 mg a day. There can sometimes be challenges with getting that medication into people's systems. And Dr. Kowalczyk is adding that respiratory sedation is much less of a risk with the bupe, the benzodiazepine, since it's a partial agonist, which is a very, very important point. And then they're in a setting where they are being monitored. And so I guess I'm a little less concerned about the sedation aspect of it and more like, we got to get the fentanyl use disorder under control. And Dr. Kowalczyk has made some really excellent points in the past about people just having to get on to methadone because Suboxone just really, really is not holding folks. That partial agonist does not do it's just the fentanyl is just like, get out of here. And so that I think is probably one of the things I'll say, but I'm going to try to let Dr. Kowalczyk, because I know she's doing, and we.
Oh, and I know we're at time, but yeah, I would say, starting this person day one, and then some of the adjuncts that are being used are also sedating. And so I think, just directly attacking those receptors and getting them stabilized might have made this a lot smoother process for them. There's also, you can taper off of the buprenorphine, or you can dose until discharge. They will have, buprenorphine withdrawal, in the carceral setting, which is no fun. but they'll be comfortable during their hospital stay. I would argue since she did have 6 or 7 days there that, yeah, maybe tapering is a little bit kinder or gentler, but I would have pushed to higher doses faster or just started with methadone if we were worried about precipitated withdrawal with inducing her onto buprenorphine, within 24 hours or so of her last fentanyl use. You do have methadone in the hospital to use for this type of treatment. And then that could have been tapered, although the sedation risk, we do balance that. You're also in a hospital though. So she gets over sedated, you're monitoring, you know, um, you're not in that ambulatory setting, like Mr. Adams, who was commenting earlier about his treatment setting, right? So there's that differential there. And then, because I know we're already at our overtime, Dr. Shorter, I just wanted to, kind of give you opening to talk a little bit more because you're much more experienced than I am. I'm in a low resource setting with injectable bupe because that would
Yeah.
be a really great option.
Yeah, and so there have been some recent study that have come out, like in the last few months, actually, that have been talking about direct to inject buprenorphine for folks that are coming off of fentanyl. And so I think that this will look very different over the coming months, where you're seeing people that are just getting hit with either 8 milligrams or 16 milligrams of Brixadi, or they're just going right to Sublocade and getting, because the idea is that it will come into your system rather gradually. And so the likelihood of precipitating withdrawal because it's coming into the system gradually is a bit lower. And of course, if you do precipitate withdrawal, just give them sublingual Suboxone. I mean, it actually is fairly straightforward and probably pretty safe, especially in our emergency settings and hospital settings. But just get the medicine, and then it can auto taper for those people who can only get one dose for whatever reason, and you're maybe not able to connect them with service, that you can have an easier taper than trying to reduce brother. Um, so some people are doing it like when they present. I've like anecdotally talked to some people and they're looking for like a cows of a 3. This person that you're talking about came in with a cows of what, 7, 15, 17. Hit them with it. Go right away.
Thank you so much, Dr. Shorter, Dr. Kowalczyk, and to the rest of our hub. To all of you that have attended, and to Dr. Keough for presenting this case. We hope some of your questions were answered and you were given some feedback and insights from the hub and our audience members. Thank you all again for attending today's session. As a reminder, to claim your CME credit for today, you must text by midnight tonight. Text the number that was shared in the chat by Karen. And we also kindly ask that you request, we kindly request that you complete the post-session survey for some feedback. We look forward to seeing everyone at our next Echo session on December 11th, and have a great rest of your week. Goodbye, everyone.